Good evening. We're back with another live webinar. This month's topic is on the evolution of ACL reconstruction, basically the history of ACL surgery. A replay of this will be posted to our Facebook and YouTube channels. And if you have any questions, just drop them into the comments and we'll address them at the end. My name is Piasecki. Just so you know who I am, I'm a sports medicine surgeon at OrthoCarolina and have been there now since 2008. And I'm a sports surgeon, which means I do pretty much every surgery in the shoulder and knee except joint replacement. But it happens that the most common surgery I do of all is ACL reconstruction. And that's something that's been a real passion for me throughout my practice and in my professional career. So it's a real privilege to be able to talk to you about some of these things that bring us back to the history of this operation, which is super common. And I'm hoping you'll get something out of it. So we're going to start off here just talking a little bit about the importance of history just to begin with. I mean, the concept of going back in time is something that's not new, obviously, but one of the main things that I think is important, especially in surgery, when we think about the history of it, is just learning what has been done before, trying to do a better job than has been done in the past, and avoiding some of the mistakes that happen. We try to do the best thing we can for our patients, but we learn as we go. And sometimes you learn new things that make you think differently about what we're doing. And so figuring that out is important. And also it gives you humility. I think being humble and making sure that you appreciate that we don't always have the answers and being thoughtful about when we do surgery and when we don't is really important. So that in mind, I'm just going to show you a little bit of basic anatomy of the knee so we're all on the same page here. So when we talk about the knee joint, we're obviously talking about the femur bone, which is in this picture above. You can see the femur, and then the tibia is the bone underneath. And then ligaments are basically these strong connections that bring the bones together. And highlighted here is in yellow is the ACL. And that stands for anterior cruciate ligament. It's really important in the knee to keep it stable, especially with twisting activities. And over time, if you're active without an ACL, and this is the reason we do surgery for this in the first place, it'll often cause damage to the knee. So that's the whole purpose of it, and that's what it looks like. When we do ACL reconstruction today, basically what we do is we drill a bone tunnel on both bones, the femur and the tibia, and we stretch a piece of tissue between those tunnels to duplicate what the old ligament was doing. And this piece of tissue is called a graft. If you look up ACL surgery online, you'll see a lot of description about what a graft is. And there's a lot of discussion about that. But this is essentially all that we do in the operation. We basically replace the old ACL with a piece of graft tissue. Now, just to go back in time, when we think about the ACL, I'm talking really, really far back. The ACL really, it was first described by a Greek surgeon in Rome, a guy named Galen, who was the first to describe the ACL as actually a stabilizing structure in the knee. Before that, like in ancient Egyptian times, humans used to think that the ACL was part of the nervous system. And really after Galen described it, I don't think there was a lot of interest in it. It sort of disappeared in the historical record for 2,000 years. And it wasn't until the early 1800s when two German brothers who were anatomists in Germany described what happened if you took a cadaver knee, somebody who had died, and you cut the ACL inside the joint, and they found that it made the knee really unstable. So that was the first recognition in medicine that it was important for stability of the knee. The first report of there actually being an ACL tear in human beings, obviously it had happened before that, but wasn't until 1845 in Ireland when a 25-year-old drunken man fell, hit his head, and sadly died. And they noticed that his knee was super swollen, and they did, during the autopsy, a dissection of his knee joint. And this is actually a drawing on the right here showing the ACL being torn. So it's this little stump of ligament, which is there showing the tear of the ligament. It wasn't until 1895, though, that any surgery at all was tried for this. So we knew that it was an injury by the 1890s, but nobody really had the courage to do surgery on it until a London surgeon named Mayo Robson tried to repair. And that's what's depicted down here in these pictures, basically just taking what was left of the ligament and suturing it back into the bone. And some other surgeons around that time added a little bit of tissue to the repair, but this was really the only thing that was thought of to try. but it did not work great. The tissue didn't heal well, and it was considered maybe an option to do something different. About 20 years later, another London surgeon named Haygroves performed the first reconstruction of the ACL. So this surgeon took a piece of tissue from the outside part of the knee called the fascia lata, and he remade the ACL with that. This is a picture of him and then a diagram showing what he did. And it actually looks pretty similar to what we do today, but it was not a minimally invasive type operation. So the picture on the photograph on the right are the size of the incisions in a human knee that were used to do the surgery. This was a really massive operation. Excuse me. And it took a long time to recover from this. It was in an attempt to help people, but it really was not super effective. And so we entered a phase after that where really the ACL wasn't addressed very much. It was sort of just in limited spurts from the 1920s to the 1960s, probably in part because World War I was ending. There was the Great Depression, World War II, a lot of other things in the world were happening, and the importance of this injury really wasn't appreciated. And so non-surgical treatment really is what most physicians did for this. And this is a picture here on the right of one of the first ACL braces that were used for patients that actually injured the knee and then had instability that was a problem. They just put you in a brace. Surgery was done, but only in extreme cases. And they did a lot of different trials with different types of grafts. So what's called a BTB graft, which is one of the most common grafts performed today, essentially is a graft that comes from the patellar tendon in the front part of the knee, quadriceps tendon grafts, hamstring grafts, synthetic grafts, and even the meniscus, which we now would never do today. But all these things were tried to reconstruct the ACL. This is a picture showing a hand drill that was used back in the 30s to drill the bone tunnels, and a big open incision that showed kind of how they reconstructed the ACL at that time. It really wasn't until the mid-70s that any type of regular surgery was done for these injuries. And this was what was called the first round of extra-articular reconstruction. What that means is reconstructions that involved stabilizing the knee on the outside part of the joint. And it was in the 70s that people started to realize, hey, this is actually a more common injury than we realized. What should we do about it? And the first surgeries that were attempted with any regularity were going back to those first repair attempts. And they tried this and realized that it really wasn't working great. About half the patients that had repairs back in the 70s failed. The ligament doesn't heal well inside the joint. And so a number of different things were tried. Surgeons basically said, look, it's not going to work to do anything to the ACL itself. We'll try to stabilize the outside part of the knee. And a number of different reconstructions were tried to do that. In the early 80s, it was recognized, though, that if you just put tissue on the outside part of the knee, it really didn't do a great job of stabilizing things. And so they went back to the ACL itself and did what were called combined reconstructions, where, as is shown in this picture here, a piece of tissue from the outside part of the knee and then one of the hamstring tendons from the inside part of the knee were wrapped around the back of the knee joint. This yellow U-shaped structure you see there, that's really what the overall construct looked like. And it worked for a while, but they figured out sometime in the early 80s that extra part of the graft, which is shown in this diagram here, really wasn't working great. It really wasn't adding very much to the equation. And they actually realized in the research that was done back then that part of the reconstruction, that part of the surgery really just either added stiffness to the knee or it stretched out and really didn't provide any clinical benefit. So it was at the end of that phase in the early 1990s that we entered into a different era. And this was called the transtibial era because right around that time, the ability to do arthroscopy, to use a camera to look inside the knee joint, became widely available at different hospitals. And surgeons realized this was so much easier than making these massive incisions. And they figured out that if you drilled your tibial tunnel and then you use the tibial tunnel to get to the femur bone, which is what's drawn in this picture here, you could actually get your femoral tunnel for the ACL in a pretty good position. And this is really what took off. This approach, which was called the transtibial ACL reconstruction used a free graft of tissue, either the hamstrings or a patellar tendon, a strip of patellar tendon, did great. And it did way better than the massive incisions of the mid and early 80s and before that. And it really took off. In the 1990s, if you had an ACL done, this was probably the way that it was done. And across the board, no matter how you looked at it in terms of how patients felt, how quickly they went back to sports, how stable their knee was, this really beat everything that had come before. So it was really considered the mainstay, the gold standard of ACL surgery. Once we got into the early 2000s, though, and we're always trying to make these things better, but people started to ask the question, can we do even better than that? And at the University of Pittsburgh, there was a surgeon who suggested that maybe we could reconstruct the ACL with 2 grafts instead of 1. And the research that was done here, I think we actually got off track a little bit at that time. People were thinking it was about how many grafts were used, but really what that research showed us is that the position of the graft made a bigger difference. This diagram that you see here, it shows a yellow arrow, and that's really where the transtibial reconstructions were putting the old ACL graft. And we realized it wasn't about the bundles, but if you put graft tissue lower down where those 2 circles are shown here, more where the normal ACL would attach, the patients did way better. And so this really refocused attention on doing things without the transtibial approach, because it was recognized that the reason we weren't really getting things positioned that great is because we were going through the bone of the tibia, and it doesn't give you a lot of flexibility. So other approaches were developed around that time. The 2 that are shown here are still the most commonly performed today, the so-called AM portal approach or the transfemoral approach. And both of these were moving away from going through the tibia itself and coming outside the knee. So it gave more flexibility to try to position things in a better way and try to get better results. This era was really what we call the anatomic ACL reconstruction era, where surgeons were really trying to get things positioned perfectly and not settling for something that was almost where it should be. But things changed, and we continue to ask questions, and the anatomic era came to an end too, because in 2010 to 2013, we started to see that these patients that were having these cutting edge ACL reconstructions maybe weren't doing quite as well as we thought. So there was a questionable return to play. Only about half of these patients, it looked like in some studies, were actually getting back to play as well as they were before the surgery. And in some really high risk groups, we actually saw that the failure rates of that surgery were approaching the same rates as the repairs back in the mid 70s. And so there was a motivation to try to do even better, and that pushes us into the phase that really surgery is in right now for the ACL, which is a look back and kind of a resurgence of trying to add tissue to the outside part of the knee. So round 2 of an extra articular reconstruction. And this really came about because an anatomist in 2013 dissected the knee, and this is a diagram of a knee that was dissected in 2013. And this particular anatomist published his results, and he suggested that there was maybe an additional thickening of tissue on the outer part of the knee that we maybe hadn't paid enough attention to, called the anterolateral ligament. And it's ALL for short, which gets really confusing because it looks just like ACL. But it's actually a different structure, and a number of different studies were done to look at this and to try to figure out, is this important? Does it actually provide stability to the knee? And a number of studies were performed that looked at that, both looking in just cadaver knees and clinical studies. And many of them have suggested that for some knees, adding this extra tissue will provide extra stability to the knee. This is a little bit controversial still. There's some surgeons, I'm one of them actually, was a little skeptical of how beneficial this actually is, but it is the thing that you'll hear about a lot. If you have an ACL tear, in some situations, surgeons are now recommending that you add tissue to the outer part of the knee to give it better stability. Okay, so that is a whirlwind tour through the history from 1895 all the way to 2025. If we look back at that, some of the lessons that we've learned, there are two main lessons that inform us today. The first is that the most important aspect of the surgery is the femoral tunnel. So that tunnel that we drill on the femur bone is the most important. It is the leading avoidable cause of failure of this operation. And so we're really, really, really careful about how we create the femoral tunnel. In a joint like the knee, where you're putting a lot of weight through the knee, if you think how many steps did you take today, something like 1.5 times your body weight passed through your knee with each step. And so if something is just not perfect, it's easy for it to not work. And the reason it really matters on the femoral side of the joint is this diagram here. So the bending angle for the graft as it goes inside the knee, it's pretty much a straight shot through the tibia. But when it gets to the femur, it has to take a sharp turn, and that increases the forces on the graft. So the position and the angle of that tunnel makes a really big difference for whether the surgery actually ends up working. And the position of the tunnel itself, the hole that is drilled to create the bone tunnel, the position makes a big difference too. If you're high up in the knee versus low down on the bone, it makes a really big difference for the forces that are seen. And this is a study that we published about 3 years ago, a computer simulation of a graft. The blue cylinder is a graft, and on the left is a graft that was placed like the old transtibial approach, and on the right is some of the newer anatomic approaches. And you see that increased color is the amount of graft force that is seen, which increases because the position and the angle of the tunnel is more extreme. The second lesson we've really learned, if we look back at all that history, is that there really are only two options for grafts that aren't positioned just right. Either the graft survives the knee and it constrains the knee and doesn't perform the function it's supposed to perform, or the knee survives the graft and stretches it out and it doesn't function anyway. So neither of those are good. The old transtibial approach was an example, as we look back in history now, where the graft was surviving the knee because the graft was put in a place where it didn't see a lot of high forces, but it didn't reconstitute the normal function of the joint. And the other approaches, the anatomic approaches, because they were placing the graft in a place where it was seeing a lot more force and stretching out, is an example of the knee surviving the graft. So the knee moves on during rehab, but because the graft is overstrained, it stretches out and then doesn't work very well. And so the answer to where we're headed now, we've done a lot of research in our sports center here on new options for ACL surgery. And this is the approach that most of us are using now. It's called a hybrid transtibial technique, which uses a new system that brings a drill guide through the medial portal, and a guide pin is directed through the tibial tunnel. And it allows you to position the tunnel in the right place, lower down than the old transtibial approach, but to create a tunnel that's not very angulated. So it really combines the best of both techniques. And when we've looked at this, when we've studied it in cadaver models and done our own finite element analysis, the computer simulation, it looks like it's achieving what we want it to. It creates the perfect tunnel aperture without much angulation at all, and it decreases graft forces significantly compared to the anatomic techniques. And as we look at the clinical data, when we studied this in patients over a long period of time, over the last 10 years, we've actually looked really deeply at this. The failure rates are very low, just like the old approaches that weren't putting grafts necessarily in the right place, but weren't seeing a lot of graft force. But also this has the lowest complication rate of any of the techniques. So we feel very good about this being maybe the next evolution of this surgery. So quick summary of how we got here. I know it's a lot. We go back all the way to the early 1900s when simple repairs were performed. And then in the 1970s, these extra-articular reconstructions were performed on the outside part of the joint. That didn't work great. So surgeons added back a reconstruction of the ACL, and then we realized maybe it was the graft inside the knee that really mattered the most anyway. And in the 1990s, when we were able to do arthroscopy, we got the transtibial technique. And that worked great for about 10 or 15 years until we started asking questions. This is what happens when you ask questions in surgery. You start trying to change things. And these newer anatomic techniques were developed that put the tunnel in a different position. And we realized those changes were maybe increasing the failure rates. And so from 2010 until now, we've had this new wave looking at adding tissue to the outside part of the knee, just like we did back in the 80s. Probably the direction we're headed in the future is just going back to the basics and positioning our grafts in the right place using something like a hybrid transtibial technique. So that's it. That's a lot of information I know. I hope it's instructive for you guys to understand kind of how we try to think about things, how we try to make things better in surgery, and how we adapt as time goes along. Let's see, do we have any questions for this? Okay, so first question is, how long is the recovery after ACL surgery? So that's a great question. It really, the quick answer is it depends. It depends on the graft that's used, the recovery that's used, the technique that's used, and it depends on what you're trying to get back to. So recovery depends on your baseline and what you're trying to return to. Most of the time, most of us, back in the transtibial times, actually, recovery was less. It was like 4 to 6 months. And we've realized that it takes longer for the graft to heal and for the knee to be safe. So now it depends on the surgeon, depends on the technique. For my ACLs, I typically quote a time frame somewhere between 6 and 9 months to get back to doing aggressive cutting, pivoting, twisting sports. But there's a range there because you need to get back the muscle balance and control in the knee to make it safe so that you don't have a repeat injury. There are some surgeons who recommend, especially if you use some of the grafts that take longer to heal, waiting 9 to 12 months, and that's not necessarily wrong. But it's definitely longer than 6 months, and it depends a lot on when you get back strength and coordination. Excuse me. So the next question is, the recovery and future prognosis different depending on going with a cadaver ACL versus a patellar tendon reconstruction? So the answer to that is probably. It depends on the patient a little bit. Usually the cadaver grafts have a little bit of an easier recovery early on in the time after the surgery, but it does take longer for those grafts to heal. And the main issue with cadaver grafts in general, in order to make them safe to go inside your knee, they have to be sterilized really aggressively. And that sterilization process usually will weaken the tissue a little bit. We do know that in patients that are much more active, that the cadaver grafts tend to stretch out a little bit more. So they take a little longer to recover from, even though it's a little bit easier in the first month or so. And the failure rates for highly active people are definitely higher. So usually my preference is actually to do a patellar tendon reconstruction in most patients. It usually gives you a much quicker recovery and has the lowest rate of re-tear. So it does differ, but the right choice really depends on what your goals are, and surgeons have different preferences for that. Okay, so I had the patellar tendon method done 10 years ago, but sometimes I have pain when I wear sandals. Is there any reason for this? So probably the pain, well, it really depends on where the pain is and the nature of it, but it is really common after all ACL surgeries. It's not probably specific to the patellar tendon graft, but all ACLs can cause some scar tissue in the front of the knee that can make the knee sensitive. And after any ACL injury, no matter how you have the surgery done, it's pretty common to have a little bit of cartilage wear and tear that comes from the injury itself, because when your knee pivots, it can actually bruise the bone, and that will often, over time, it can lead to a little bit of wear and tear of the cartilage. So all those things can contribute to the symptoms of having pain. Usually, if you're not having tons of swelling and it's not causing you to limp on a regular basis, it's probably not super serious. But if it's holding you back and limiting you, feel free to come and see us at OrthoCarolina. We could take a peek at it, make sure it's not something more serious. Okay, so is neuromuscular training the most effective method for preventing ACL injury? What that's referring to, neuromuscular training, is trying to get the muscles around the knee after. Usually we use it after surgery because it's hard for this to substitute for having a normal ACL. So you have your ACL tear, your injury, and then you have the operation. And neuromuscular training is a way after the surgery to make your knee resilient so that the mechanisms that we use when we're not thinking. So if you think about playing soccer, let's say, if you're going out and playing soccer, you're thinking about making a play or passing a ball. You're not thinking about your knee. And those are mechanisms that aren't conscious. They occur in the background of our subconscious brain. Those mechanisms are really hard to get back after an injury and after surgery. So neuromuscular training is used after surgery to try to prevent repeat injury. It's also used before you have an ACL tear to try to prevent you from tearing it in the first place. And there is some evidence that decreases the rate of ACL tears. It's not huge, but it does have an effect. So for most really high risk sports, like soccer, for instance, there are a number of neuromuscular training programs that are done in the off season and throughout the actual season itself to try to minimize the risk, but it's still probably going to be there in sports that are risky. So what's the likelihood of re-tearing your ACL after surgery? That's a great question. That's been a moving target over the past 50 years, actually. And it depends, as you might have noted from that presentation, it depends on how the surgery was done, especially how the femoral tunnel was created. It depends on the graft, it depends on the sport, and it depends on what you do after the surgery to try to get back some of those mechanisms that are designed to protect you. The number that we usually quote to patients in my practice when I see patients, and I prefer the hybrid technique that I mentioned to you, if you're using your tissue, especially if it's a patellar tendon graft, and you do everything that is necessary after the surgery to get it to heal properly, and we do everything we're supposed to do in the operation, usually the re-tear rate is 5% or less. But if you choose an allograft and you have a different risk profile, and there may be other factors in your knee that might increase that risk, it can be higher. And some patients are at higher risk than others, and there are ways we can try to minimize that risk. But usually it's around 5% for me. Great question. Why are soccer girls more prone to ACL tears? So, well, there are two little aspects, two details there. One is female athletes, and the other is soccer. Soccer in general is one of the highest risk sports for ACLs, male or female. And it really has to do with what you're asking your body to do when you play. It's a lot of changing direction really quickly, and that's what the ACL is designed to do. But you're doing it so aggressively, so many times when you're playing soccer, that it increases the odds that your ACL may just see a lot more force than it can handle. And so it's just riskier. It's riskier than a sport like hockey. You know, hockey, you tend to be more straight ahead. You're turning, but you're wearing thick pads, and you're less likely going to twist on your knee in a way that'll tear it. Soccer is a lot of pivoting, changing direction. So soccer itself is really high risk. Female athletes are much more likely to have an ACL tear than male athletes, depending on the study that you look at. It's 2 to 4 times more likely for a female soccer player to tear an ACL than a male athlete. And it's pretty controversial, actually, why that is. It may be related to the level of play that we see and the forces that are applied. There are differences, obviously hormonal differences in bone structure and the forces that may get applied, male versus female. It probably comes down to a complex issue with lots of different factors, but it likely has to do something to do with the way the muscles are balancing and protecting the knee. But it's not that female knees are not as strong. It's just an issue of what they're being subjected to. Okay, I tore my ACL about 9 to 10 years ago, and it was treated as a wrenched knee. Can it be repaired after this long of a period? That depends a little bit too, but often yes. The issues that can come into play if you've had an ACL tear for a long time, one of the reasons we try to do surgery on these injuries in the first place is to try to prevent additional damage from occurring. And so sometimes the benefit of the surgery may be a little bit less if it's 10 years later and there has already been some damage. But the two reasons to do the surgery are to try to improve function, and the second is to try to preserve the knee. So whether it's going to be worth it or not really depends on if those are symptoms that you're having. And so in some ways, if you've not had a lot of wear and tear or problems in the knee yet, there is a lot of benefit to preventing that from happening beyond now. And if your knee is unstable when you're doing change of direction activities, that would be a reason to think about the surgery to try to give better function. So it's not just at the time that's passed. It depends on the state of your knee now, but the answer is it definitely could. Do you ever do knee replacements from the anterior angle without cutting the muscles? So full disclosure, I don't do knee replacements, but when knee replacements are done, and we have many specialists here at OrthoCarolina that do almost just knee replacements. They're very, very good at them. There is a way to move around the kneecap, and the incisions that you saw for that first ACL reconstruction were massive. They don't do that for knee replacements now. I mean, they use really small incisions, maybe like this neighborhood, and they're very clever, the surgeons that do these, to work around the muscles. So there are a number of different approaches that are minimally invasive for doing knee replacements, and they come in from the front, a little bit like the incisions you saw, but way smaller. Okay, how many times can an ACL be repaired in the same knee? So that's a toughie, because that really depends too. It depends on if ultimately with any surgery, it depends on if the benefit of doing it again is greater than the risk and the downtime for the patient. So it's pretty rare that the benefit of doing a redo ACL outweighs the risk and the downtime and the likelihood it's going to work if it's beyond, I would say in general, 5 or 6 times. We never try to do it that many times, and many patients actually choose just not to if they've really struggled that much and had that many operations and it hasn't worked. Most patients say, look, I'm just not going to keep going. Each time you redo it, it gets more complicated. There are potentially longer recoveries, and it becomes a little bit less predictable. So the real answer is you could do it as many times as you want, but at some point it becomes maybe not worth it. I have seen patients in complex situations that have had 6 or 7 ACLs, and it has been in rare situations worth it to keep going in those situations. But usually after 2 or 3, both doctor and patient are usually saying, it may not be worth it. Well, let's look at the options. We'll talk about it. If it looks like it's going to help you, we definitely consider it. But it's a mutual decision about whether it makes sense to do more than that. But it's not an absolute number. Where do you see the Bayer procedure fitting into the future of ACL repair and reconstruction? That's a great question. The Bayer procedure is basically a new way to try to do a repair of the ACL. I would say this is controversial. There are some surgeons who feel very strongly this is a great option, and I wouldn't say it's not an option. The problems I have with this approach personally are that it is another attempt at doing something that we learned back, as you guys know this from the presentation I just gave you, back in the mid-70s. 50 years ago, we tried repairs, and it really did not work great. The difference now with the Bayer procedure is that additional tissue is being added to the ligament to try to make it do better. That actually was tried back in the early 1900s. I showed you a picture of that too, and it didn't work great then either. There is some research that shows that doing this procedure is more successful at getting the ACL, what's left of the ACL, to actually attach to the bone. But the main obstacle to making this work is not so much getting the reattachment, but making sure that the tissue that actually heals is tight enough to be functional. So if you imagine you got a rope that's normally like this long, if you get it to heal back, but it's this long, it's going to be loose. And that is one of the things I have personally seen in patients that have been referred to me after this procedure. They may have an MRI that looks really good, but their knee's still loose, and it's essentially the same as if they still had an ACL tear. So it's not that it can't work, but I personally think it's most of the time a little bit too unpredictable when you have 95% success rate with an ACL reconstruction. I'm not sure it's quite good enough to warrant putting patients through the recovery to try to get to that place. It usually doesn't work great. So I'm a little pessimistic on it, to be honest. I think it probably doesn't have the way that it's being done right now, a huge role. But people continue to look at it, and it is something to pay attention to. Yeah, this is a great one. How do you define a good outcome after ACL surgery? So there are a million ways that we as surgeons doing research have tried to define the outcome after ACL surgery. The best way, I think, is how is the patient doing? I mean, does your knee feel good to you? Are you able to go back and do the things that you want to do, which is the main purpose of the operation? I think that's the best outcome. So you have to ask a patient, are you happy? Do you feel like you had surgery or not? Fortunately, this is a really, really good operation. And most patients get to the end of the recovery and are very happy with how they did and feel like they actually can't even tell they had an operation after 9 to 12 months. Most people say, I can't tell a difference. So that would be a really good outcome, and that's what we shoot for. That's an interesting one. Are there any hobbies that you or other surgeons do to improve their hand steadiness and dexterity? Beyond just doing surgery for a million years before you can actually do it in practice, which is appropriate. You should be really good at it before you actually operate on people. This is probably going to be a different answer for everybody you ask. I've always been an athlete myself. I think that a combination of athletics and fitness on the one hand, and then the endless number of like projects my wife gives me to do around the house to repair things. I love doing that too. And it's just fixing things. That's really orthopedic surgery in general, is fixing things. It's not a lot different than a lot of the home improvement projects, believe it or not, that you would see. The instruments even the drills and mallets and everything look pretty similar. So I just do an awful lot of that stuff and try to stay fit. And I find that works great for me. Great question. What is the process for dealing with meniscus tears along with an ACL tear, and is the future prognosis any different? So meniscus tears, those are the shock absorbers in your knee. There's one on the inside and one on the outside part of the joint. It's very common to have both an ACL tear and a meniscus tear. Some of these tears don't need treatment at all. And in fact, we'll evaluate them at the time of the ACL surgery. And if they don't need treatment, we just leave them alone. The way that we handle it at the time of surgery, if it needs something, is we try to figure out if it can be repaired. And that's always a better option because the meniscus is really important in the knee. We try to preserve it if we can. So we'll evaluate the tear while we're doing the ACL surgery. We can see it with the camera that's in the joint at the time. And if it looks like it needs to be fixed, we stitch it back together at that time. Some tears won't heal, but will get worse if they're left alone. So those are ones we might trim a little bit. But the answer is we deal with it at the time of the surgery. The prognosis of the surgery, it does get impacted by the meniscus. Most of the time, most meniscus tears either aren't huge and don't need to be repaired and don't affect the outcome or the recovery, or they heal great and it's easier for the meniscus to heal along with the ACL, so it actually doesn't affect the recovery in terms of therapy and how long it takes to heal. But there are some meniscus tears that can affect the cartilage health and can impact how well the ACL will actually do after the surgery, but they're pretty rare. So the answer is most of the time we deal with meniscus tears at the time of the ACL surgery, and usually it doesn't affect the prognosis in a significant way. Okay, well, thank you guys for attending. That's all the time that we've got. Remember that a replay of this will be posted to our social platforms, and I hope it was interesting for you. Have a great night.